before I come in next time and ask you just to be yes, all of you will start. Okay? Do you have any questions about seminar 1 and 2? Did you guys get a chance to go watch those videos? You have those videos online, you have those PowerPoints online. You have so much to do, right? But in case you do, in case you have any questions, you know about my style of lecturing. I love it when it's interactive. I love it when it's two-way. Sometimes the questions are so many that we don't finish the curriculum, which is okay, right? And the questions will come into your mind only if you start having some cases which you can connect to. Okay? So what's going to happen the next 4 days? Day 1 to day 3. I'm going to teach you principles of correcting AP. AP stands for anteroposterior malocclusion, which is either class 2 or class 3. On the last day, I'm going to teach you detail about smile stream, how to trace a Ceph, how to trace a model, and how to make VTOs and everything about smile stream. In fact, not the last day and a little bit on the third day also, because I have so much to teach you on that. And that's how we've been doing ortho for all these years, until MOS is coming. I'm sure he's retaking it because last time that you were in the class, we were working only on smile stream. That had a lot of information. I was telling you about this last time. When I come here in seminar 3, I'm going to teach you all of this. In MOS, when we make the diagnosis, it is very, very quick, but you will not know exactly what went into the diagnosis. When I teach you smile stream this seminar, you will probably have a lot of knowledge when you walk out of the room on day 4. Okay, so stay prepared. We're going to give you some introduction to mechanics. What is mechanics? What do you mean by mechanics? Mechanics principally means moving your molars. If your molars are class 1 and you have crooked teeth, the moment you align your teeth, the treatment is done. Isn't it? You just have to align. Everything is going to be class 1. But once you align everything and the molars are not class 1, then you have to move the molars into class 1. That's called mechanics. If your molars are class 2, you have to move the lower molar forward. If your molars are class 3, you have to move the upper molar forward. That's called mechanics. Okay? And these mechanics are different a little bit when aligners and braces are concerned. Leveling aligning is in the class 1. If your class 1 posterior occlusion case is completed or level and align, this technique is called a one-wire technique. Okay? You write it down. One-wire technique is you start the case and you complete the case entirely just with one wire. Which wire are we talking about? 18 by 25 heat activated nighttime. This wire is a rectangular wire. Why is rectangular wire important? Because it has some control on roots. It's going to move your roots labially, lingually, establish the torque, it's going to create the arch form, it's going to level the curve, speed, all of this. So when you have one wire technique, you start the case with a round night-eye. Round night-eye wires are the best wires to correct rotations. Once the rotations are corrected, you do 18 by 25. If your posterior occlusion is class 1, you're done. Okay? So you will have cases like that, and that's where we will make money. Because you don't want to start a case, you treat the case for 4.5 years, and you charge them very little money. That means you spend a lot of time on the chair, not doing anything at all, right? You want cases where you start to finish, you don't remember the patient's name at all because you saw them 4 times and the treatment is done. Okay? So we in POS recommend that you see the patient every 2 months. We don't see them every month. Whether it's braces or it's aligners, we see them every 2 months. If you have a case that finishes with class 1 posterior, one wire technique, start with round night-eye, move to 18 by 25, see them every 2 months. Once in 6 months to 18 by 25, you will be done. Okay? The advantage of a one wire technique over an aligner is that one wire technique, the occlusion is far more stable than the aligner because it has control on the roots. It has a better control on the roots. Okay? So if you ask me which one would I like to treat my patients with, the simple malocclusions, braces or aligners, my go-to appliance is always braces. Why? Why would you go to braces all the time? Because you don't have to depend on the patient's cooperation. Aligners, patient has to wear it for 22 hours a day. I have two daughters, and both of them were treated orthodontically, and both of them were treated with braces. Because I'm at home, I can monitor if my kids are wearing it well. Still, I feel the occlusion, the root movement, the torque, all of this is far, far more superior in braces compared to aligners. So I'm not saying you can't do that with aligners. You can do it, but you really need to have a good patient. So you cannot clap with one hand. You cannot. Your skill is not enough. The patient also has to be equally motivated. Unfortunately, the next generation that we're treating right now, the attention span and the enthusiasm span of treatment is very short. I see that they wear it very, very well for the first 4 or 5 months, and then the entire enthusiasm almost dies. So there are certain plans which are called comprehensive aligner plans. Comprehensive aligner plans will require at least 2 years of aligner therapy. 2 years. And that's a very important plan for correcting class 2. So we're going to talk about that today. Okay? Comprehensive plans are cases where you have moderate class 2. Like you have 4 millimeters of class 2. You guys remember what is 4 millimeters class 2? It's end on, half cuspid class 2. If you have 4 millimeters of class 2, you can correct 2 millimeters but the lowers coming forward, 2 millimeters with the uppers going back. How does the upper go back? Can the upper go back? Yes. It can happen with aligners. Why? Aligners work with push forces instead of working with pull forces. If you want to move the upper teeth back with braces, you need to have something behind the teeth to pull the teeth back, which is skeletal anchorage. But if you have aligners, aligners work with push forces. They are the go-to appliances for distalization. Okay? This plan is called distalization. Distalization plans work only with aligners. Because if you have braces, now you need skeletal anchorage. Skeletal anchorage for distalization comes from the zygoma. That's a difficult surgery to do. Okay? And you may have a lot of unwanted forces. You can create a gag, etc. That's why we advise you, whenever you have a distalization plan, automatically I would tell you go to aligners. Does it make sense? So whenever I tell you something, just note this down. I told you the best practices, right? You can note down many notes, but whatever points I'm telling you, I'd like you to note it down and go back and copy that in a Word document. So that becomes your textbook. Whenever you go search for the word distalization, it will take you here. Distalization plans are predictable with aligners. How much can you distalize? If you have a missing 8 and you're distalizing the entire upper arch, you can distalize up to 2 millimeters. If you have a missing 7, there's something called upper 7 extraction plan. Now you will do an upper 7 extraction plan when you have an upper 8 visible in the OPG, on the panoramic X-ray. Okay? If the upper 8 is present and you extract the upper 7, almost 100% of the time, the upper 8 comes and occupies the space of the 7. If you see this patient after 5 years, this patient will look like a non-extraction patient because all the teeth are present in the patient's mouth. So differential diagnosis of 7 versus 8 is if you extract 8s, then you can get 2 millimeters of distalization. If you extract 7s, you get 4 millimeters of distalization. And which appliance will you use? Aligners. Okay? Yes, question. if you extract the 7, then you must have an 8. So this is called a molar substitution plan. Okay, the word is molar substitution. You are extracting, you are substituting. You're removing the 7 and bringing the 8 in place. And this happens successfully in a case where 8 is uninterrupted. Okay, so write these things down. Molar substitution. Molar substitution is replacing the 7 with 8. For you to do that, you must check on the OPG if the 8s are present. And the 8s have to be favorable in the direction of eruption. And 8 should be uninterrupted. If the 8s are already erupted, then you cannot move the 8s forward. Okay? But the 8s are uninterrupted and the 7s have been extracted. As the 8s erupt, they will come and take the place of 7 almost all the time. Okay? This plan is called molar substitution. So can you tell me at what age would you think about doing this plan? What should be the age of the patient? Anywhere between 12 to 20. Because at 12, the 7s would have erupted. And at 20, 8s would erupt. Isn't it? So do you have this window period? The 7s have erupted, get the 7s out. Before the 8s have erupted, you have good amount of space behind the 6. Crystallize the 6 into class 1. This is a comprehensive plan. The patient should be really cooperative guy to wear the aligners 22 hours a day along with elastics. Only then this plan will work. Okay. Remember I told you what's my take? If I had to choose an aligner case, I ask the patient a single question. How clean is your room? If you are one of the patients who keeps everything nice, tidy and clean, then that's the good aligner patient. If those guys, especially those teenage boys, come into your clinic, they don't even comb their hair. Have you seen them? Give them elastics, they would never wear it. Something about these boys. Girls usually cooperate well. But still, for them to do I have a boy I'm treating now for class 2, visualization plan. This is the comprehensive plan. What do I mean when I say comprehensive plan? What's the meaning of comprehensive? Anybody doing Invisalign here? Invisalign has a comprehensive plan. That's the most expensive plan. Okay? The comprehensive plan. Comprehensive plan allows you unlimited number of refinements. Refinements is once your case is not going as you plan, you can scan again. And you keep going and you scan again, you keep going. They give you a 5-year window period. No matter how many aligners you use, you pay nothing more. That's called a comprehensive plan. So when you do digitalization plans, they have to be a comprehensive plan. Because if you're expecting the patient to wear aligners for 2 years and expecting the aligners to do exactly the same job, you may be disappointed. Right? So you have to do a comprehensive when you work on your MOS software and you go to your class 2 malocclusion, they give you certain amount of simulation based on mechanics. All the simulation that they give you is based on mechanics. If you see a case which has more than 4 millimeters of class 2, then you know you cannot correct this with class 2 elastics. It will not give you a class 2 elastic simulation. You understand? Simulations are predictions. It gives you, these are the methods by which you can fix class 2. Okay? Let's just refresh on that a little bit before we go into detail. What are the methods that you know of correcting class 2? I'm the one who taught you this in seminar 1. I'm sure you know all it. Methods to correct class 2. We classify them as non-extraction, extraction, and surgery. Isn't it? These are the methods to correct class 2. What are the non-extraction methods to correct class 2? First and the most common is class 2 elastics. Okay? Second, distalization. Class 2 elastics bring the lower teeth forward. Distalization will take the upper teeth back. Okay? these two methods of correcting class 2 non-extraction. What are the methods of correcting class 2 extraction? Either you can extract the upper force and the lower force, or upper force only. Right? These are the two methods by which you can do class 2 extraction. What's the method to do surgery? Do you do upper surgery or the lower surgery? Most likely it's the lower mandibular advancement. If you have a prognathic maxilla, you can still extract and retract. So it may not really require a surgery. But if you have a small mandible, the most common surgery that you will do will be a mandibular advancement surgery. Okay? These are methods to correct class 2. Let's just classify based on mechanics and how much of class 2. When you have these two plans, how much class 2 should be there for you to correct? Anything less than 4 millimeters. Less than 4 millimeters of class 2, you will either do with class 2 elastics or this dimension. When you do an extraction, you can have anywhere between 4 to 6 millimeters of class 2. Okay? And if you have a big class 2, like 8 millimeters class 2, where there's a value on your cephalometric X-ray called the ANB. ANB is an angular measurement which is formed connecting the A point, that's the deepest point of your maxilla, to the nasion, to the B point, is the deepest point of your mandible. When you draw this angle, this will show you how much class 2 you have. If this angle is more than 4 degrees, it's called class 2. If this angle exceeds 7 degrees, it becomes a red flag or surgery. So when you have full class 2 with A and B greater than 7, this is considered to be a situation where you have to consider surgery. Mandibular, that means the bones are not on top of each other. When the bones are not on top of each other, it's very difficult for you to fix the teeth on top of each other. Alright? This is how you classify. All of this information, if you find this hard to remember, is fed into your software. So it classifies how much class 2 you have. It takes the A and B value from your cephalometric AI tracing, and then it gives you simulations based on what you have written on the board. Okay? Initially, we advise you to limit yourself to class 1, mild class 2, or mild class 3. If you do that, you will fall into this category. Only you will have a non-extraction class 2 plan. You will not even have a discretization plan. Initially, we asked you just to stick to simple class 2 cases or simple class 3 cases. Simple class 3 cases is what? How much? 2 mm class 3 non-growing. Okay. It's also important to have non-growing. If your patient is growing, it's a chance that class 3 can keep becoming worse as they grow. Okay. You have, the simulations are not new to orthodontics. You've been having the simulations with many other softwares. For example, if you see Invisalign and they come with an iTero scanner, that's the first scanner that was invented. Okay? So when this guy comes to my practice iTero, he scans it. After he scans the patient's teeth, he presses a button and automatically the post-op images start showing up. Have you seen that in Invisalign? It's very, very good marketing tool. And the patients will be very impressed. If they come to you with crooked teeth and they scan this is how you're going to look later. What was the problem with that simulation? That the Invisalign shows you versus what the MOS shows you. Invisalign does not consider the cephalometric X-ray. So it thinks all the patients are skeletal class 1. Okay? So the predictions that they show you are not as accurate as what you would have on your software. Your software also considers skeletal malocclusion. Make sense? That's why this is becoming more and more predictable. If you have skeletal malocclusion, the software does something else. What does it do? There is something called an endpoint. Endpoints are the upper incisor and the lower incisor have to finish at a proper inclination. That's called an endpoint. When you have skeletal malocclusions, the endpoint will change. The endpoints change to accommodate the skeletal malocclusions. They are called dental compensations. Dental compensations are movement of the upper and lower incisor to a different angulation, not the class 1. What would it be in a class 2 case? The upper incisor will be more retroclined, and the lower incisors will be more proclined. The endpoints have been modified in a skeletal class 2 case in your MOS software. Why would you have to modify this? My question is, why do I have to modify the endpoints? Because the bones are not on top of each other. But the patient doesn't come to you because they want a class 1 canine. What does the patient want? The patient wants no overjet. If your patient has overjet, they can feel it, right? And they don't like your finish. If I modify the endpoint, I am correcting the overjet. Isn't it? My canines will still be class 2, but I will have no overjet present because my upper incisors are retroclined and the lower incisors are more proclined. This allows me to still treat a skeletal class 2 with reduced overjet since I am changing the endpoints. You understand? So if your MOS software shows you A and B value is skeletal class 2, the endpoints will automatically be modified. See, all of this is automatic. It's years and years of planning that's gone into the software so that we don't have to think about it for every single case. Do you guys understand? Or it's too fast? Is it okay? Normally you have an ideal inclination for upper incisors and lower incisors. Whether you extract a case or you don't extract a case, you expect incisors to finish at the ideal inclination. Okay? The ideal inclination is when the upper incisor and lower incisors make an angle, the angle will be 125 to 130 degrees. That's the ideal interincisal angle. When you have skeletal malocclusion, you will never finish with the ideal interincisal angle. They will be modified. Okay? Modification is by dental compensations, which is retroclined upper, proclined lower. Whenever you treat a patient, whether you're treating with EOS brackets, MBT brackets, any brackets, you need to understand the science behind how you want to finish. So you will still be allowing your incisors to change the inclination just to correct the overjet, because when you have overjet when you finish, patients will not have. Okay? How can you change the inclination? If your patient has got all the teeth are straight, and the upper incisors and the lower incisor is straight, but you have overjet, how can I change the upper incisor inclination? By adding IPR in the upper arch. If I had IPR only in the upper arch, I can allow my upper incisors to retrocline. Isn't it? As incisors retrocline, what happens to the overjet? It reduces. Okay, so this is what your thinking should be when you would add IPR in the upper versus lower. In other words, if you we're talking about class 2, right? I'm not talking about class 3, okay? We'll speak about class 3 later. In other words, whenever you see an aligner setup where you have class 2 finish and the overjet is more, you have to make sure the lower arch has no IPR. You understand? Adding lower IPR in a class 2 case will worsen the overjet. Understand? So it's all about the endpoints. So when you have class 2, the skeletal class 2, do not add IPR at the lower, because lower IPR in a skeletal class 2 will worsen the overjet. So in Medit software, we have all of this incorporated for you so that you don't have to miss out on any of these points. This is a slide I showed you in seminar 1. I'm sure you all have a picture of this because I asked you to take a picture of this. If you haven't, you can still take it. It's there in your PowerPoint as well. This is called scope of bite classification. You have class 1, you have class 3, the next slide has class 2. There are so many methods to correct class 1, so many methods to correct class 3, and several methods to correct class 2. Now, when you want to choose which of these methods I should be using, you need to see how much class 2 I have in the case. If I have class 2 from 1 to 3 millimeters, the first 5 options are suitable for me. Okay? And you see the braces and aligners both get highlighted. That means this simulations can successfully be achieved with braces or aligners. Okay? But as we go down, as the amount of class 2 increases, you will see when you need extractions, we suggest you do only with braces. Aligners to close a bicuspid extraction space may have a lot of unwanted movement. Similarly, when you have a distalization plan, it says aligners only, okay, because it works with push forces. Aligners are better at push forces. All of this is fed into the software based on how well your scans are, will trace for you and will give you what suits the patient the best. And when you have surgery requirement, you have widths, which is built at 6 degrees. That's when surgical simulation is present. Okay. Why do we need a class 1 canine? Why are we talking about class 1 canine all the time? Because when you have class 1 canine, you will have 2 millimeters of overjet and 2 millimeters of overbite. That's what looks very, very aesthetic and the patient likes it. If the amount of overjet is more, and the patient starts feeling the upper incisal edge touching the lower leg. They feel the touch. Sometimes when I make crowns, when I did veneers, I did a veneers for a patient before I came in here last week. I made it to the natural inclination. He had no overjet. I gave him a larger overjet, or I had a prepless veneers. Okay, so I did not grind so much, and the veneer came with its own thickness. The patient had worn away dentition, worn out dentition. So I gave them a good height to width ratio. I put it in the patient's mouth for a trial. It looked excellent, but he didn't like it. Why do you think he didn't like it? The color was great, the shape was great, the finishing was awesome, everything was good, but he didn't like it. The moment I put it in the patient's mouth, it was touching his lower lip. Okay? That's exactly what they feel when you give them an overjet. And with this orthodontic knowledge that you have now, you can apply this in your veneer cases. Try it. Whenever you do veneers, do you guys do veneers? It's very common, right, for spelling dentistry. When you do veneers and you give a finish where your overjet is a little bit more, you'll say, no, the teeth are too much outside, I'm not liking it. But if you look at the patient's face, it looks excellent. And you think this guy is too much demanding, he's not the ideal. That's not what he's trying to tell you is, this was not touching my lower lip before, but now it's touching. That's why you chase a class 1 canine. When you chase a class 1 canine, automatically your amount of overjet and overbite is 2 millimeters. What happens? Your midline is centered. Okay? The inclination, all of that you have is very, very good. The occlusion is very stable. If the occlusion is stable, the patient does not have too much of relapse. We have a perfect occlusion. The occlusion takes care of the retention by itself. Okay? If class 1 is not achieved, then you may consider a balanced posterior occlusion. Okay? Or add reasonable amount of IPR to idealize the overjet. Okay? Does this line make sense to you? This is where you're changing the endpoints. Change the endpoints, the overjet is corrected. This is your dream, and you wish every case finishes like this. And if you do, it's going to be great, and it is doable. If you have a cooperative patient and you have good knowledge, you can achieve results like this. Okay? These are Andrews' 6 keys of evolution. Dr. Larry Andrews is the guy who wrote down these 6 points. The first one is class 1 molar, not the canine. Molar. If you have class 1 molar, automatically everything ahead of it will be class 1. If you have a class 2 molar, you cannot, what did I do? Wow. If you have a class 2 molar, you cannot have a class 1 canine because the molar dictates where the canine will be. Does it make sense to you? If you want to have a class 1 canine and you're not extracting anything, you have to have a class 2 molar. There will be situations where the molar is class 1, but the canine is class 2. Have you seen that? It's very common for you to have molar class 1, canine class 2. When does that happen? When you have a deep curve of spleen. Okay? When you have a deep curve of spleen, the molars will be class 1, but the canine will look like it's class 2. The moment you level the curve of spleen, canine will also become class 1. Okay? It's very common to have that problem. Questions?